The opioid crisis in the United States is ongoing and well publicised, with overdoses involving opioids contributing to 2/3 of total overdose deaths. Although the United Kingdom has not seen the same levels of use as the US, the safety of opioids is still a major issue. Currently, around 13% of the total population in England are prescribed opioids, and that doesn't even include over-the-counter medications or those who are taking opioids without a prescription. And following the COVID pandemic, with increased difficulty in accessing healthcare, it's actually thought that this number is much higher than this. In this video, I'm going to let you know why opioids don't work for chronic pain and why the repeated prescribing of these drugs is a major issue. Hey friends, welcome back to the channel. If you're new here, my name is Mahin and I'm an advanced practice physiotherapist specialising in pain management based in the UK. On this channel, we explore ways to improve our interactions with those living with pain to help them create healthier and happier lives. Although I can prescribe medication, most of my job is actually helping people reduce off high levels of medication that aren't helping their pain. Therefore, I focus on helping people develop non-medication strategies for their pain, as these are found to be much more useful in the long term. Today, I'll let you know why opioids for chronic pain don't work. Before I start, I want to be clear that I'm only talking about opioids for the use in chronic non-cancer pain. Opioids have a use in acute pain, for cancer-related pain, and also have a use in end-of-life care. So in this video, I'm specifically only talking about opioids for chronic non-cancer pain. Examples of opioids from weak to strong include cocodamol, codeine, tramadol, morphine, whether in tablet form or liquid morphine, oxycodone, buprenorphine patches, and fentanyl patches. And at the higher end of the scale of opioid strength, we have heroin. And all of these medications are the same type of drug, are all a derivative of morphine, and all come from the opium poppy. Common side effects include constipation, nausea, itchiness, drowsiness, vomiting, headaches, and cognitive difficulties such as with short-term memory and concentration. They can also lead to euphoria, urinary retention, slow down breathing, which can lead to respiratory distress, and also lowers heart rate and blood pressure. Often then, a second medication is needed to help with these side effects, which then comes with their own set of side effects, and that medication treadmill just continues. So tolerance happens when there is a need to take higher and higher doses of the same drug to have the same opioid effect. Dependence is the need to keep taking a drug to avoid withdrawal symptoms. So if we ever stop taking the drug that we would get withdrawal symptoms, that's when we know that someone may have reached a stage of dependence. And finally, addiction is intense drug craving and compulsive use. Now, the reason I want to go through these three terms is a lot of my patients, when they come to see me and they're on opioids, are worried about addiction. And addiction and dependence are very different things. We often confuse the two terms. So often people think that dependence, which is the need to continue taking a drug to avoid withdrawal symptoms, is addiction, when actually it's not. Addiction is when there is compulsive use and actually that craving of the drug itself. And there's a lot of other kind of psychological factors that are involved with addiction that perhaps don't come with dependence. Most people, if they've been on an opioid for a period of time, will develop that dependence just because the body gets used to having that medication. When we take it away, withdrawal effects are there. And it's really important to note that withdrawal effects not only happen in those people who develop dependence, but also those who have developed tolerance to a medication as well. We say that over 100 milligrams of morphine equivalent daily dose, and you are at risk of addiction. And when someone is taking over 120 milligrams of morphine equivalent daily dose, then they have actually reached an addiction profile. And when someone reaches this level, it's very unlikely that they're getting any more benefits, but they are having increasing risks of side effects and long-term risks as well. One of these risks includes opioid-induced hyperalgesia, which is just a big way of saying that the opioids that someone's taking is actually leading to higher pain levels and pain sensitivity. And this usually happens because of an oversensitization of the nervous system through taking these drugs for over a period of time. It's also really important to mention here that in studies that have looked into the effectiveness of opioids on chronic pain, they've actually found that 10% is seen as a good outcome. Okay, a 10% reduction in pain is what I'm talking about here. Even with opioids, which are seen as pain relief or analgesic medication, a 10% reduction in pain is seen as a good outcome. And this just proves that there's no such thing as a painkiller because there is no medication that completely gets rid of pain. So here then we have to weigh up actually whether that 10% reduction in pain, if somebody gets it, because don't forget that's a good outcome, not everyone will get that, is worth the side effects and the risks that come with taking that medication. So all of these opioid drugs mentioned interact with the body in the same way by binding to opioid receptors found in the brain, spinal cord, and other areas of the body. Weak opioids such as codeine bind to less than 50% of these opioid receptors, whereas strong opioids such as your morphine and fentanyl bind to more than 50% of these opioid receptors. Opioids work by hyperpolarizing nerve cells, which stops the action potential or charge from crossing the synapse between two nerves and prevents the signal from traveling up the nervous system. This is also why it can be a challenge coming off these medications, because when we suddenly take away the opioid, there's nothing bound to those receptors anymore, which allows the action potential to flood on through, increasing the pain response. This is why it's really key to gradually wean off opioids rather than stopping them altogether. If you're watching this video and you're taking opioids yourself, I'd really urge you to speak to a medical professional, whether that is your doctor, GP, physician, or your pain specialist, about gradually reducing off your opioids. There needs to be support and guidance with this, and this video is only for educational purposes only, as always, and it doesn't replace proper medical advice. So I spoke about opioid tolerance before, and the way that opioid tolerance works is the brain cells that have these receptors on them become less responsive to opioid stimulation over time. Therefore, more opioid is needed to stimulate the VTA brain cells of the mesolimbic reward system to release the same amount of dopamine in the nucleus accumbens and produce the same amount of pleasure and pain relief to that provided at previous lower doses. Opioid dependence and withdrawal comes from a change in another important brain system, a part of the brain based at the bottom of the brain called the locus coeruleus, or LC. Neurons in the LC produce noradrenaline and distribute it to other parts of the brain where it stimulates wakefulness, breathing, blood pressure, and general alertness, amongst other functions. When opioid molecules link to mu receptors on brain cells in the LC, they suppress the neuron's release of noradrenaline, resulting in drowsiness, slowed respiration, and low blood pressure, all of which are common side effects of opioid use. With repeated exposure to opioids, however, the LC neurons adjust by increasing their activity. Now, when opioids are present, their suppressive impact is offset by this heightened activity, meaning that pretty much normal noradrenaline levels are released, and the person taking these opioids feels more or less normal. However, when opioids are not present to suppress the LC brain cells' enhanced activity, the neurons release excessive amounts of noradrenaline, triggering the shakes, anxiety, muscle cramps, and diarrhea, all of which are common withdrawal effects. But the good news is, if no further opioids are taken, or if they're taking at a lower dose, the LC neurons will largely revert back to their pre-drug condition within a few days or weeks. As I mentioned before, it's really important that opioids are not stopped straight away, especially if on high doses or if someone has been taking that opioid for a long period of time. By stopping the medication straight away, it can lead to significant withdrawal effects and also increased pain. And that's just because the body is expecting a level of opioid to come in, and when it isn't, that's when we get all these withdrawal effects that I've mentioned before. So as I mentioned, if you are watching this video and you are taking opioids yourself, please consult your doctor, GP, physician, or pain specialist about beginning a reduction plan with support. Opioids were only ever designed for short-term use. Even to this day, they are only recommended in acute pain following injury or after surgery, for cancer-related pain, and in end-of-life care. They are not recommended for chronic pain, and they've been taken off the list of recommendations. And under the NICE guidelines, the most recent ones in 2020 for chronic pain, it's actually suggested that if anyone's on opioids, that we discuss reducing gradually with the patient. Unfortunately, due to limited studies that go beyond 3 months, and also prescribing habits that are formed over many years, patients are left taking opioids for many months or even years. When I was writing my essay for my prescribing course, I actually found 0 studies that looked at the effectiveness of opioids beyond 3 months. So even though opioids can have a short-term effect, that effect cannot be extrapolated to beyond 3 months for chronic pain. And we see this pattern often of a patient who has pain, who goes to see their prescriber and is given, a weak opioid like codeine or cocodamol, which works for a little bit, stops working. They go back to that same prescriber, who then gives them something like morphine or Oromorph, which works for a little bit and then stops working. And they go back to the prescriber and then they're put on something stronger like a fentanyl patch. This is seen so often, and it's just because we become very tolerant to opioids very quickly. So So we need higher levels of medication to have that same effect, and then they stop working, and then we need high levels again to have the same effect. And that cycle just keeps on continuing going round. So basically, the longer an opioid is taken, the less effective it becomes over time. But we also have the increased risk of side effects and longer term risks as well. I then see patients who have gone through this journey that I've just described, and they are on high levels of opioids that aren't helping their pain, but they're experiencing significant side effects, and they report really not feeling like themselves at all. And this can be really, really worrying for patients because they can see how their life has changed. And also what's worrying for me as a clinician is that some of these patients don't even know how high a level of opioids that they're actually on. I had a lady the other week who was on 440 milligrams of morphine equivalent daily, bearing in mind that the maximum recommended dose is 100 milligrams. She was on 440 and she didn't even realize that that was a large amount. She actually thought that she was taking, a moderate amount of opioid. She knew she was taking, a fair bit, but she had no idea at how high a level she was actually taking. The good news is that when we're looking at the overall pain management picture, medication actually makes up a very, very small part of this. And there are lots of other things that we can do to help with pain in the long term. If you're living with chronic pain yourself and would like to learn more about these other strategies to manage your pain, then check out this next playlist here. If you're a healthcare professional and are working with people living with chronic pain, then check out this playlist next. Thanks for watching, take care, and I'll see you on the next video.